When patients enter Phase 3 cardiac rehabilitation, they often believe the hardest part is behind them, and in many ways it is, because Phase 1 focused on early mobilization in the hospital. Phase 2 introduced supervised monitored exercise and structured conditioning, but Phase 3 is where independence begins. And this is precisely where many people unintentionally limit their long-term success by thinking that cardiac fitness simply means walking longer on a treadmill, holding onto the rails, watching the clock, and slowly increasing duration without advancing quality, intensity variation, muscular conditioning, or movement complexity. And while treadmill walking is absolutely valuable as a foundational aerobic activity, the heart is not designed merely for repetitive straight-line movement at a constant pace. It is designed to respond to dynamic physiological demands such as posture shifts, resistance changes, breathing adjustments, muscular recruitment, and controlled variations in effort. And this is why Phase 3 cardiac rehabilitation must move beyond passive endurance work and into intelligent, progressive, and functional cardiovascular conditioning that prepares the patient not just for exercise sessions but for real life. Because real life involves climbing stairs, carrying groceries, turning, lifting, reaching, bending, balancing, and responding to unexpected physical demands. And if the rehabilitation strategy does not prepare the cardiovascular and musculoskeletal systems for those multidimensional movements, then recovery remains incomplete. So the advanced movement philosophy in Phase 3 is built around 5 core pillars: aerobic variability, strength integration, mobility and flexibility enhancement, neuromuscular coordination, and breath-driven cardiovascular efficiency. Beginning with aerobic variability, instead of maintaining a constant speed for 30 minutes, we introduce structured interval patterns that are medically safe and individually prescribed, such as 2 minutes at moderate intensity followed by 1 minute at slightly higher intensity within approved heart rate zones, because interval conditioning enhances stroke volume, improves vascular elasticity, and trains autonomic adaptability without requiring extreme exertion. And when patients learn to control intensity using perceived exertion scales alongside heart rate monitoring, they develop confidence in understanding their body's signals rather than fearing them, which is psychologically transformative in cardiac recovery. Moving to strength integration, one of the most underestimated aspects of Phase 3 rehab is resistance training. Yet muscle tissue is metabolically active and acts as a peripheral pump assisting venous return, which reduces cardiac workload during daily tasks. So incorporating light to moderate resistance exercises such as seated rows, supported squats, wall push-ups, resistance band pulls, and step-ups performed with controlled breathing can significantly improve functional capacity, insulin sensitivity, and long-term cardiovascular resilience. And importantly, resistance sessions must emphasize exhalation during exertion to prevent Valsalva maneuvers that may spike blood pressure. Because breath control is not optional in cardiac training, it is essential. And speaking of breath, diaphragmatic breathing and paced respiration drills help recalibrate sympathetic overactivity that many cardiac patients experience after surgery, angioplasty, or myocardial events, as chronic stress activation can keep heart rate elevated unnecessarily. So teaching patients to synchronize movement with breath creates a neurologically efficient pattern that reduces strain while improving oxygen utilization. And mobility enhancement is another crucial element, because stiff thoracic posture, tight hip flexors, and restricted shoulder mobility can mechanically limit respiratory expansion and movement efficiency, thereby indirectly increasing cardiac workload. So gentle dynamic mobility routines, including thoracic rotations, shoulder circles, supported lunges, and ankle mobility drills, performed within safe parameters, allow the entire kinetic chain to function more smoothly. And when movement becomes efficient, the heart works smarter rather than harder. Neuromuscular coordination also plays a major role in advanced Phase 3 programming, and this includes balance drills such as tandem stance, walking, controlled directional stepping, light agility ladder patterns, or side-to-side weight shifts, all of which enhance proprioception and reduce fall risk, particularly in older cardiac patients, because a fall can undo months of recovery progress. And when we combine these elements thoughtfully into weekly programming, we design sessions that may look like this: a 5 to 10 minute gradual warm-up emphasizing posture and breath, followed by 20 minutes of interval-based aerobic conditioning on varied equipment such as treadmill, stationary cycle, or elliptical depending on orthopedic comfort. Then 15 minutes of supervised resistance circuits using light dumbbells or resistance bands focusing on large muscle groups, followed by 10 minutes of mobility and cool down with structured breathing control. And this comprehensive approach not only improves measurable cardiovascular metrics like VO2 capacity, resting heart rate, and blood pressure control, but it also enhances patient autonomy, because confidence is a medical outcome too, and many individuals in phase 3 still carry subconscious fear of overexertion. So education about warning signs such as persistent chest discomfort, unusual breathlessness, dizziness, or disproportionate fatigue is integrated into every session, empowering patients to differentiate between healthy exertion and concerning symptoms. And long-term success also depends on progression strategy, which must be gradual and data-guided, meaning increases in intensity, duration, or resistance occur one variable at a time rather than all simultaneously, typically following the principle of 10% incremental adaptation, allowing cardiovascular remodeling without overload. And equally important is recovery, because the heart is a muscle that adapts during rest. So ensuring adequate hydration, sleep, nutritional support rich in lean protein and anti-inflammatory foods, and structured rest days supports vascular repair and muscular rebuilding. And when patients integrate lifestyle movement beyond formal sessions, such as choosing stairs mindfully, practicing short walking breaks after meals, incorporating light stretching before bed, and maintaining daily step awareness without obsession, they transition from rehabilitation to lifelong cardiovascular stewardship, which is the true goal of phase 3, not merely completing a program but transforming identity from cardiac patient to heart-strong individual. And this transformation requires mindset shift, structured planning, accountability, periodic reassessment of functional capacity, and collaboration with cardiology teams for safe parameter updates. Because cardiac rehab is not about restriction, it is about intelligent expansion of capacity. And when we go beyond the treadmill and train the whole body as an integrated cardiovascular system, we build durability, metabolic strength, vascular flexibility, neuromuscular confidence, and emotional resilience, all of which dramatically reduce the likelihood of future cardiac events while enhancing quality of life. And ultimately, phase 3 success is measured not by how long someone can walk in a straight line, but by how confidently and efficiently they can live their life without fear, limitation, or unnecessary strain on their heart, which is why advanced movement strategies are not optional luxuries but essential components of comprehensive cardiac recovery.